Thank you for kind introduction. I'm Dr. Kim from Incheon Sejong Hospital, and I'm interventional cardiologist. Today, I'd like to present the benefit of intensive lipid lowering with ATOVAMIBE. This is my content. There is some overlap slides, so I'd like to skip some slides. Here. According to recent guidelines, LDL-C target has been lowered, and ATOVAMIBE combination therapy is more strongly recommended. Compared to the 2016 guidelines, in the 2019 treatment guidelines, patients with ASCVD, severe CKD, DM with target organ damage with major risk factors were classified as very high risk, and the LDL-C target was lowered from 70 to 55 milligram per deciliter. And in addition, it is recommended 50% or more reduction from the baseline cholesterol level. This is the main changes from 2016 to 2019 European guidelines are summarized in this table. Depending on the risk category, the target cholesterol level has been lowered, and in addition, it is recommended to reduce it by more than 50% from the baseline in patients with very high risk and high risk patients. In 2022, Korean Society of Lipid and Atherosclerosis guideline also recommend that similar target LDL cholesterol in patients with coronary artery disease. This is very high risk group, and it is recommended that the target value be lower than 55 milligram per deciliter and reduce it by 50% or more compared to the baseline value. In particular, if diabetes has been present for more than 10 years, target organ damage is present, and there are 3 or more major cardiovascular risk factors, it is recommended that the target value be lower than 55 milligram and reduce it by 50% more and treated as the very high-risk patient. This is the treatment algorithm. First, assess the cardiovascular risk, and then initial treatment start with statin, and those increased until the target level is reached. If the target level is not reached, after maximum tolerated dose of statin, ATOVAMIBE and PCSK9 inhibitor is added. As you already know, this landmark study, which was published in NEJM 2015, and the first study to prove the additional benefit provided by lowering LDL cholesterol level below the previous target when ATOVAMIBE added to statin therapy. Over 18,000 post-ACS patients were enrolled, and median follow-up was 6 years. This intensive treatment group, simvastatin plus ATOVAMIBE, compared to the standard treatment group. The graph shows the mean LDL cholesterol change according to the time. LDL-C level dropped sharply in the combination group at 1 month and was maintained to the duration of follow-up. You can also see that the value of lipid profile, especially total cholesterol, triglyceride, and hsCRP, also decreased significantly at 1 year. The primary outcome result combination group demonstrated a statistically significant reduction in event over 7 years of follow-up, and the ischemic stroke event was also significantly lower in the combination group. When comparing the primary outcome according to the pre-specified subgroup analysis, the result favor trend to the combination group, and the group shows statistically significant better result in older age group and the diabetes group. This study emphasizes the more aggressive lipid lowering therapy is warranted for both high and very high risk patients. Non-statin lowering LDL cholesterol reduced CV event and can be performed without additional adverse event. Patient may be eligible for the second-line lipid-lowering therapy with ATOVAMIBE to the first-line choice if patient therapeutic goal is not achieved at maximal tolerated dose statin, and patient are intolerant to statin, and patients who are contraindication to statins. Next, I would like to talk about the high-intensity statin monotherapy concern and unmet needs. Among the statins, atorvastatin is the moderate to high-intensity statin. In 2013, ACC guideline recommend 40 to 80 milligram of atorvastatin and 20 milligram of rosuvastatin as a high-intensity statins. There are lots of well-established RCTs on the efficacy of high-intensity statin, especially atorvastatin, on the primary and secondary prevention. In this study, high-intensity statin improved the ischemic stroke and major CV events, such as death, hospitalization of ACS, non-fatal MI, and cardiac arrest. However, there are still existence of residual CV risk despite the statin treatment. In this study, patients were classified according to the coronary heart disease risk categories, and the changes of lipid profile were evaluated. The atorvastatin provides greater reduction in non-HDL cholesterol after dose titration, and greater percent of patients taking atorvastatin achieve non-HDL cholesterol target, but overall, the LDL target goal achievement rate very low. This lipidemia in international study 2 is a multinational observational cross-sectional study. This data from 808 patients enrolled in Korea, 500 stable CAD and 308 ACS. Only minority of patients with stable CAD and ACS were under their target LDL goal achievement. The mean statin dosage was 70 milligram per day of atorvastatin equivalent dose. The statin dose was not sufficient in the majority of patients. One of the concerns of high-intensity statin is hepatic toxicity. This data shows the higher incidence of hepatic toxicity in statin dose-dependent manner. Another concern is myopathy. This data shows that myopathy occurs in approximately 10% of patients using statin. The risk factor is muscle pain with another lipid-lowering therapy, unexplained cramp, history of elevated CK, and hypothyroidism. And importantly, the new onset diabetes. This data from the meta-analysis of 13 RCT involving 90,000 subjects without diabetes at baseline shows that statin treatment increased the incidence of diabetes by 9%. And drug-induced adverse event was increased when using intensive dose statins. Therefore, despite the established benefit of high-dose statin monotherapy, residual risk and unmet needs remains. What other options do we have in this situation? Lipid can come from diet, stores in adipose tissue, and from the endogenous synthesis. ATOVAMIBE inhibits dietary and biliary cholesterol reabsorption in small intestine. In combination with statin, we can reduce the endogenous cholesterol synthesis and upregulation of hepatic LDL-C receptor, and thus enhancing the clear of LDL cholesterol from the bloodstream. This is so-called dual inhibition mechanism. In the published phase 1 and 2 clinical trial, ATOVAMIBE 10 milligram per day significantly reduced the LDL cholesterol level, approximately 18%. And this is previously mentioned in IMPROVE trial. The combination of statin and ATOVAMIBE, we could reduce the primary endpoint of convergent CV death, MI, and hospitalization for unstable angina, and coronary revascularization and stroke. This is prospective randomized open-label clinical trial conducted in Japan as a multi-center. This trial aimed to demonstrate the first primary prevention cardiovascular disease with ATOVAMIBE monotherapy in patients over 75 years old, LDL cholesterol level over 140 milligram per deciliter, and patient with no history of coronary artery disease. Usual care plus ATOVAMIBE and usual care alone was compared. And in this ATOVAMIBE group, non-HDL cholesterol and GG and concentration were significantly reduced compared to the control group. In primary outcome result was reduced 34% in the ATOVAMIBE group compared with the control group. According to the 2017 ACC expert consensus decision pathway on the role of non-statin therapies, consideration that may favor initial choice of ATOVAMIBE include this situation. Patient with less than 25% additional lowering LDL cholesterol required, patient with recent ACS, cost consideration, and easy use of oral agent, and patient's preference, and age greater than 75 years, and eGFR less than 60 milliliters. And in 2018, ACIS guideline told that high intensity or maximum statin, if on this statin, LDL cholesterol greater than 7 milligram per deciliter, adding ATOVAMIBE is reasonable. And if PCSK9 inhibitor is considered, add ATOVAMIBE previously before PCSK9 inhibitor is recommended. And next, I would like to talk about the enhanced efficacy and safety for atorvastatin and ATOVAMIBE combination therapy. In this prospective randomized double-blind test, when co-administered with atorvastatin and ATOVAMIBE, there is a significant incremental reduction in LDL cholesterol and TG levels. In this multi-center double-blind randomized study, 196 patients treated with atorvastatin 20 mg received atorvastatin 20 mg plus ATOVAMIBE 10 mg or atorvastatin 40 mg for 6 weeks. Adding ATOVAMIBE 10 mg to atorvastatin 20 mg produced significant greater reduction in LDL cholesterol than increasing atorvastatin dose up to 40 mg. Serial research conducted with a baseline atorvastatin 40 mg shows similar result. And safety profile and incidence of liver and muscle adverse experience were generally similar between two groups. In this multi-center randomized double-blind active control clinical trial, ATOVAMIBE added to atorvastatin 10 mg produced significant greater improvement in key lipid parameter and significant greater attainment LDL cholesterol target than doubling of atorvastatin or switching to rosuvastatin at the compared dose. The incidence of pre-specified adverse event of special interest is low and with no significant differences seen among these groups. This is the product information. Last year, low-dose combination drug was released. The previous speaker spoke these products. So I would like to close my presentation with this message. Lower is better. Atorvastatin is recommended as high to moderate intensity statin. Long-term beneficial effect on CV disease and mortality is established, but there is a concern about intensive statin and monotherapy, intensive statin monotherapy and unmet needs is left. So ATOVAMIBE add-on therapy is effective treatment option for this patient. And patient who therapeutic goal is not achieved at the maximal tolerated statin dose, or patients who are intolerant to statin. ATOVAMIBE added to atorvastatin produced significant greater improvement of lipid parameter and greater attainment cholesterol target than doubling atorvastatin dose or switching to rosuvastatin at the comparable doses. Thank you for listening to my presentation.